So last but definitely not least, we've got Dr. Yun, who's going to actually convince us that we can now use functional precision oncology to predict immunotherapy response, which has been holy grail.
Thank you. Thank you for the opportunity to speak. I'm the last speaker on a very long day, so I'm going to try to keep it very short. And I do have a poster, so I'd be happy to discuss. And I would really love feedback from this community, especially from the skeptics, what more we need to demonstrate, how we can really implement this in the clinical and research settings. So please feel free to think broadly. I do have a financial disclosure. I'm a co-founder of Empiri, and this technology that I'll be discussing today has been licensed to Empiri, so definitely financial conflict of interest. And seeing Pam actually reminded me that I did get funding through MD Anderson from Astellas using this technology as well, but I won't be talking about that at all here today. So, as you know, functional precision medicine is an approach where we take patient tumors and expose them to drugs directly to measure individual personalized response to drugs, right? And as David mentioned, this idea has been around for a very long time. And especially in the early days when they were using these patient-derived cell culture models, it has failed fantastically in the clinic. So there are many skeptics, but there are other more newer generations of models like organoids or PDX models, right? But they have limitations as well. So first of all, to make PDX models costs a long time and a lot of money. And also the take rate for organoids and PDX models is not universal. So you cannot model every patient. So can we do better? And another major limitation of those models is that they lack tumor microenvironment. And we heard a lot of talk in this session about the importance of the immune cells and efficacy of the immunotherapy when proper tumor microenvironment is present. And from my own study, I would like to just underscore this concept by showing this data. So my lab performed single-cell RNA sequencing from 44 GBM patients, and we profiled over 200,000 cells, and of which about 87,000 cells were myeloid cells. So GBM is an immune cold tumor. There are very few cells, but it's chock full of myeloid cells. So when we profiled that many cells, we could identify 9 different molecular subtypes of myeloid cells, and using just the gene signatures for these different myeloid cell subtypes, and ignoring everything about the tumor cells, mutational profile, molecular profiles that we've been talking about for the last 2 days, you can predict patient survival just looking at these gene signatures, meaning by looking at what kind of myeloid cells are present in the patient tumor, you may be able to tell the prognosis. And interestingly, gene signatures associated with tissue-resident myeloid cells, microglia, tend to predict better survival, and all bone marrow-derived myeloid cells predict worse survival. So I hope I convinced you the tumor microenvironment is important, which means that when we model these patient tumors ex vivo, we need to maintain these cells as well. So as I mentioned, the organoids have pretty much been sort of the poster child for these precision personalized medicine in the last decade or so. But in producing organoids or organoid chips, the first step is to dissociate the tumor, in which case you lose that tumor microenvironment, cell-cell interaction, extracellular matrix, and sort of the relationship of different cell types within the tumor microenvironment. And this varies from patient to patient. So our goal was to maintain the tumor microenvironment by making tumor slices. And there are many different tumor slice papers out there, but we spent about 100 experiments just optimizing the protocol. And key factor is that we don't use serum in our media. Pam does not like serum. He shared about this technology because it stimulates immune cells and it changes cancer cell behavior. But anyway, so what we can do is from either fresh biopsy cores as small as 18 gauge needle cores or large surgical samples, we make precision cut slices and culture them and immediately expose them to drugs. So there is no ex vivo expansion of cancer cells or selection. And then we measure changes in viability compared to self, providing absolute response, as well as relative response compared to internally controlled vehicle control. In clinical settings, we can provide these results in 4 to 8 days. In research settings, we can perform any kind of molecular and cellular analysis you do from any tumor sample. So you can take DNA, RNA, conditioned media from chemically defined media, do the proteomics, you can do spatial, you can do single cell sequencing. So we've validated that this platform works for all solid tumors, including lung, breast, colorectal, ovarian, pancreas, bladder, etc. And we have tested all treatment modalities, including immunotherapies, chemotherapies, target therapies, viral therapies, and radiation. And as you can see from these pie charts, now we've done over 700 experiments, and more than 75% of those from human tissues, either PDX models or patient tumors. So after 12 to 8 days in culture, by doing H&E staining, you can see that the tissue architecture is very well preserved, and you can see tumor components and the stromal components. And when we treat them with cytotoxic drugs, you can see that treated among the adjacent sections shows massive cell death compared to untreated controls. But does it really accurately predict patient response? So in collaboration with Dr. Scott Kopetz at MD Anderson, we performed a small retrospective clinical study. So in this case, in the first study, Dr. Kopetz performed clinical trial from BRAF mutant metastatic colorectal cancer patients, and blinded to the patient response, he gave us PDX model tumors. And we predicted response using these slices. And as you can see, we're 100% accurate in predicting patient response. And by the way, we use a simple conversion of RECIST criteria of tumor volume change to viability changes. In the second study, similarly, we performed again PDX models derived from patients involved in irinotecan plus cetuximab plus minus vemurafenib. And again, our prediction was highly accurate. So when we look at overall correlation, is very strong between our prediction and patient response. So this is in metastatic colorectal cancer setting with targeted therapies, many different combinations. So that's very promising. But we wanted to really show that we can maintain tumor-associated immune cells and stromal cells. So we started with MC38 mouse murine tumor, and we performed single-cell sequencing from uncultured 0-day culture slices and 8-day slices. And the bar graphs show that the populations are maintained over at least 8 days in culture, including T cells and NK cells. And when we do further analysis by extracting T cells and performing de novo clustering and assignment through cell states, you can see that many of the cell states are maintained. We do seem to reduce naive and early activated CD8 T cells and expansion of the exhausted CD8 T cells. And so we don't know whether these cells are maturing within the tumor microenvironment in culture, or this reflects spatial heterogeneity, because these slices are coming from different parts of the tumor. How about in patients? So my lab studies GBM. We did the same experiment. GBM is even cold. There are very few T cells, but this particular patient had lots of myeloid cells, pretty typical. And you can see the myeloid cell absolute numbers as well as proportions is maintained in culture. But how about the cellular state? So as I mentioned, we have 9 different molecular subtypes of myeloid cells. Using those signatures, we ask which subtype is present in this patient, and does the subtype phenotype change over time? And what you can see is that in this patient, the dominant population is what we call suppressive macrophage 1. And even after 8 days of culture, that is the most dominant population. So now we can say that do we not only maintain cell numbers, but also cell states, both T cell and myeloid cells as suppressive cells ex vivo. And can we do this with other tumor types as well? So there's a sample pair data analysis from 3 lung patients and head and neck cancer patients. And as you can see, at baseline and 8 days in culture, patient to patient, there's tremendous amount of heterogeneity. But overall, there are certain populations that seem to increase with culture, but overall, all populations are preserved in culture. So what can we do in the clinic? I think that's the question that was going to ask me. So in triple-negative breast cancer, Pembro has become part of the standard of care after KEYNOTE-522 successful trial. And even with the successful trial, actually the percent of patients who really benefit from having Pembro in their standard of care is about 12%. It's 10 to 12% of the patients. But Pembro, as Pam mentioned, these immunotherapies do have toxicity and they're very expensive. So $150,000 a year per patient per year, right? So at the recent San Antonio breast cancer meeting, there was a lot of discussion about the fact that we are over-treating this population of patients because 100% of the patients are receiving Pembro, but only 10 to 12% will benefit from it. So we decided, so there is a need for identifying these patients who will benefit. So we designed a study where we take a biopsy at diagnosis, do e-slice determination, and then the clinicians will determine pathological response at surgery. And I would like to highlight that the timeline for this is really different, right? In patients, it takes 6 months. In e-slices, it takes 8 to 12 days. And the goal is that after we have completed the study, we will match the patient response to e-slide response. So this is our status now. By the way, this is in collaboration with Dr. Naoto Ueno, who is now at University of Hawaii, but at MD Anderson, and Kyuson Yun at MD Anderson and the Empiri team. And so far, we have analyzed 7 patients. And as you can see by red box samples, that we saw a response to Pembro in only 2 of the 7 patients. And we see response to the combination in 4 of the 7 patients. And these numbers are pretty close to the numbers they saw in Keynote 522. But what else can we do besides looking at viability? And especially with the immunotherapies, I think a lot of the readouts, more relevant readouts, may be immune activation signatures. So in this study, in collaboration with Dr. Kim, we analyzed 8 lung cancer patients. We saw response from 2 when we added Nivo to the chemotherapies. And importantly, when we looked at interferon gamma levels in the conditioned media, we saw increased interferon gamma in wells that contain only Nivo, right? And only in responders, but not non-responders. So I think I'm getting red blinky, so I'm going to stop. But there were a lot of people who were interested in looking at therapy of mechanisms of therapy resistance, especially to MAP kinase pathway. And this is actually a study that we could show the emergence of resistance ex vivo using patient samples. These are all the potential applications of the technology. And I would like to just thank my lab, and my clinical collaborators, my collaborators at Empiri, and then, of course, patients and caregivers and funding sources. Thank you.